For those of you who are not familiar with Living with Dignity is a non-religious, non-profit Quebec organization with no political affiliation. It was incorporated in Montreal in 2010. Our work is to promote the protection of the life and the inherent dignity of people who have become vulnerable through illness, old age, or disability. Our objective is to ensure every person an end of life that is natural and respectful of the individual, which means adequate pain management and quality palliative care, and in a secure environment which best meets the needs of the patient. Living with Dignity is a citizen network that represents 5,000 people in Quebec. Just to make a quick comparison, the other organization in favor of euthanasia represent 500 people. We hear a lot about them, but we can eat them at breakfast. One of the reasons we are here today is because euthanasia raises many questions. It raises many problems. And there is reason to wonder, because basically the law carries a terrible message. Now, under certain conditions, the law allows to kill or to help other persons kill themselves. That's the basic of what they call medical aid in dying. Beyond every speech, that's the true core reality. We could say that it's the marriage between, to speak frankly, the marriage between suicide and homicide. That's what it's all about. And I'm not making that up, because to permit medical aid in dying, the criminal code had to be modified. And I'm quoting the criminal code. It has been modified to create exemptions from the offenses of culpable homicide, of aiding suicide, and of administering a noxious thing, in order to permit medical practitioners and nurse practitioners to provide medical assistance in dying, etc., etc. So in other words, it's a special permission given to doctors and nurses to have the right to kill, culpable homicide, to help commit suicide, and to inject poison into a suffering person. The debate was never, or should have never been, about whether an individual should be able to end his own life. The debate is about whether a person should be allowed to intentionally cause the death of another person, or to help that person commit suicide. That would have been very different in the media if we could have talked about that instead of autonomy and self-determination. At the end of my presentation, I hope you will be able to determine whether the safeguards initially promised are effective in protecting vulnerable patients. And I'll focus on the Quebec situation, because Canada is a vast country and every province manages euthanasia their own way, so it would take a lot of time to cover it all. I hope you'll be able to understand that challenges to the criteria of the law are inherent to the logic of euthanasia, and understand the similarities between euthanasia and suicide, and understand the effects of legalizing euthanasia on our society, and to measure their long-term social impact. So let's start with, what I'll try to do today is, it's been 2 years now since euthanasia was legalized in Quebec. Before that, there were a lot of promises, a lot of talk, a lot of projections. Now we have facts. We have our own data. So that's what I want to look at and make a couple of observations. among the promises that were made, there were a lot of talks about the exceptional measure for exceptional cases. We heard that. The robust safeguards. Don't worry, there will be robust safeguards. Very strict criteria. First and foremost, it will be, that's what they said in Quebec, first and foremost, it will be a law on access to palliative care. That's what they said. So we'll take a look at, we'll analyze the facts by comparing them with what was originally sold. What about the statistics? What about the safeguards? Has the public discourse remained the same, or has it changed since the beginning of the law? Have there been any violations of the law? So let's start with the statistics. As I just told you, euthanasia was sold in Quebec as an exceptional measure for exceptional cases. At the beginning, Dr. Aubert talked about, our health minister talked about approximately 100 requests the first year. So in reality, in the first year, there has been 469 euthanasia in Quebec, which is almost 5 times more than what they expected, what the requested were expected. 714 requests. And the second year, it came even higher, 638 cases of euthanasia for 992 requests. That's about 1% of deaths in Quebec. I just saw an article on February 12 that said that because the reports from the commission covers, I think it's from June to June, and so they made they compiled the statistics for the whole year of 2017, and they said there has been 755 cases of euthanasia in 2017. In some regions, Quebec City, Estrie, Bas-Saint-Laurent, it's almost 2% of, it represents 2% of all deaths. In comparison with Belgium, if we want to talk as a percentage of all deaths, the first year in Quebec is the equivalent of the 6th year in Belgium. And our second year is their 8th or 9th year. So we jumped right in. So even when we talk about how many they have after that amount of years, we're going faster than they are. And we can ask ourselves, and that's an ethical question, is there a number that we will consider too much? And if so, what does it mean? It wasn't a good thing. Who would complain if we had 100% people dying with the help of palliative care? No one would complain. So just to ask the question is kind of the answer. Sorry, I have a virus that everyone knows, the end of a virus that everyone knows, especially those who are not physicians. It's called, in French, it's called the man flu. That's why I drink a lot. Okay, so just a quick look at the statistics in Canada. There has been 2 interim reports covering a 6-month period. The first report concluded that there has been 970 people who died by euthanasia or assisted suicide, and then 1,179 people in the next 6 months, which represents an increase of 46.8% compared to the first 6 months. So in total, in Canada, the first year, there has been 2,149 people who died by euthanasia or assisted suicide in the first year. So the first observation we could make regarding the statistics is that the statistics explode the forecast talking about an exceptional measure for exceptional cases. Now, let's take a look at the robust safeguards. we'll try to analyze the effectiveness of their so-called robust safeguards with facts. Before, there was a lot of talk about those safeguards to reassure people. And even that should have been a sign, a warning sign for the population. Why do you need to reassure us? That should have raised a question mark for us. So before the law came into force, there were a lot of talks. They talked that there would be 2 physicians to assure the objectivity of the diagnosis and the absence of pressure, a very strict criteria. There would be a supervisory board to ensure the compliance with the act. Regarding the strict criteria, just to remind you a little bit, the person had to be insured within the meaning of the Health Insurance Act, be of full age and capable of giving consent to care, be at the end of life, suffer from a serious and incurable illness, be in an advanced state of irreversible decline in capability, and they had to cover it all, and experience constant and unbearable physical or psychological suffering which cannot be relieved in a manner the patient deems tolerable. Why am I citing all that? It's because we'll then look if that was respected. So we have to just take a quick look. There were also procedural safeguards included in the Quebec law. And it's important to say that it was included in the law because it has a different, bigger importance if it's included in the law than just a measure from the Collège des Médecins. So the request had the euthanasia had to be requested by the patient in a free and informed manner. The request must be signed in the presence of and countersigned by health or social services professional. Second opinion by a physician independent of both the patient and the first physician. And that was all supposed to protect vulnerable people. So before we take a look at their effectiveness, I have to say that those protection mechanisms are biased. Because why? The physician is the same person who evaluates, who perform the euthanasia, and then who fills the reports. So you can say whatever you want before that, but the same person will be the only witness. Which physician will write, I admit I wasn't sure he wanted to die, but I did it. No one would do that. So they have to believe the same person who evaluated and who performed the act to make sure that the criteria were respected. In Quebec, the Collège des Médecins decided that medical aid in dying shouldn't appear on the death certificate. So your uncle, you can learn that your uncle is dead, and what will be written on the death certificate is cancer. And maybe one nurse will come to you then and say, well, how do you react that your uncle is dead by euthanasia? And then that's when you'll learn that he died by euthanasia. So they can hide it at this point. So imagine in the future how hard it will be to...
So how can you relate to the statistics?
Yeah, that's right. I'll take, I think we have 20 minutes questions and then...
Do hold the questions, write them down, hold them, we'll answer them.
Yeah, but that's a good point. How do you rely on statistics? And I'll talk about that a little bit later. And in the federal law, there is also a provision called good faith. So if in good faith the physician tells, I really thought he wanted to die, it's enough to absolve him. Exactly. Thank you. We never see that in any other place in the law in our society. So the exceptional measure is not the cases. The exceptional measure is euthanasia. It has rights and privileges that we don't see anywhere else in our society. So, were there any violations of the law, of all those criteria? First year, 21 violations of the law. 21, not 1, 2, 3. We thought the first year would be, physicians would respect it, and then it would go maybe after years it would become that situation. But no, the first year, 21 violations of the law. 18 cases were the independence of the second physician. 2 cases, the criterion of end of life. The commission evaluated and concluded that the patient was not at the end of life. In 1 case, they concluded that the patient had not a serious and incurable illness. What did he have? Man flu? Who knows? But it's open to anything.
That's pretty serious though.
Yeah. Well, it's a serious matter, yeah. Second year, more violations of the law. 31 violations of the law. 20 cases, second physician again. 20 cases, 7 cases, physicians did not conduct the interviews with the patient himself. So a patient ended up to the doctor, and he just performed the euthanasia based on what the other doctor said. Well, I make sure he wanted to, it's okay, do it. 7 times. It's a lot of cases. 2 cases, the request was not countersigned by a health or social service professional. Who was it? Who was he? The ear. And 1 case, the euthanasia was performed even if the health insurance card was expired. Try to get your finger fixed without that scar. You won't be able, but for the most dramatic act that we can do, which is take on another person's life, it's okay. That's why I'm talking about privileges. So this is already a problem, but there is more than meets the eye. There's also a problem from, as you said, collecting the data. 38% of the forms received after deadlines. The physicians are supposed to send within 10 days their reports about the euthanasia. But what we see is that they send it weeks or months later. We see that there is, in 19 cases, the commission wasn't able to conclude on the compliance with the act. Why? Because in 4 cases, the commission did not receive complete information. And in 3 cases, the doctors indicated to the commission their decision not to respond to the requests. So what does it tell us?
To the request for information?
To the request for information. The commission asked for more information, and the doctor replied, well, I'm not going to send it to you. Thank you. So it tells a lot about how the physicians who perform euthanasia see this commission. And for those of you living here, we see it in the newspapers. The commission is constantly attacked. They want it out. That's what they aim for. Another problem, which is probably the most important problem, with all the cases of abuse that I said, one would think, it will have consequences, no? That's why the commission is there, to ensure the compliance, and no. No sanction provided by the Collège des Médecins the first year, and no sanction provided by the Collège des Médecins the second year. So for all those offenses, there was not even a slap on the hand. Nothing. What will happen? You think they will, the third year they will say, now I will comply with the law? No. It's just opening the door for more violations of the law. Because what do they want? They want to make it normal. So if people start to doubt and see those violations, the panic will install, and because it's still someone taking your life out. Dr. Yves Robert, Secretary of Collège des Médecins, justified his position by saying that none of these cases justify a punitive measure. since it is, according to him, simple administrative errors. 52 administrative errors. Thank you very much. We'll go to the third year. So the second observation that we can make is that this robust safeguards do not work. And we have to remember that to directly cause the death of a patient without respecting the criteria and safeguards included in the law remain, until today, a criminal homicide. So the true consequence of those violations of the law should have and could have been prison. We're talking, remember, we have to always go back to the beginning and remember, oh yeah, that's right, it's about homicide and suicide. If we lose that focus, and that's what they're trying to do, if we lose that focus, we don't even understand why people could be opposed. Try just to make that exercise by reading an article. Replace medical aid in dying by suicide. Mm-hmm. Then you'll understand the position of the physician. My doctor don't want to provide medical aid in dying. People can look at it and say, oh, what's up with this physician? But if you say, my doctor don't want to suicide me, now it takes another turn. So we have to go back to that. So violations of the law should have been taken in charge by or ended up in prison. That's a true reality. So every year the law is being abused and there are no consequences. Another aspect that I want to cover are the shifting concepts. Let's take a look at the public discourse. Has it remained the same or has it changed since the beginning of the law? Well, the facts are showing that the public discourse already changed a lot. The first major shift, we went from exception to promotion. The safeguards that we talked about became barriers to access. The exceptional measure became a response to a need. When they saw the statistics exploding, they couldn't say, oh yeah, the exceptional. That didn't work anymore. So they found their answer and they said, well, it just showed that it was a need. So it's a response to a need. And the selection criteria became injustice, discrimination. The second major shift is that we went from a law for access to palliative care to a law for access to euthanasia. Before the law, remember that it was sold as being first and foremost a law on access to palliative care. I have the quote here. That's what they said before the law. But despite that promise, in fact, the priority was always on euthanasia. There has been no follow-up on the accessibility of palliative care by the Commission for 2 years in their report. No follow-up whatsoever. Each year, they said, the variability in reported information regarding the number of end-of-life individuals who have received palliative care does not allow this data to be processed at this time. A law for access to palliative care, and that's the answer at the end-of-year report. Their explanation in 2016 was that the context of the significant transformation of the health and social services network has affected the ability of institutions to collect palliative care data in a timely manner. And the next year, no explanation. In January 8th, there was a letter published by Dr. Louise Lafontaine, who is the president of l'Association québécoise des soins palliatifs, and Dr. Christiane Martel, president of the Société québécoise des médecins soins palliatifs, addressing the commission their worries following those observations that we just made, saying that there are no data available to analyze the implementation of palliative care component of the law. The vast majority of people requesting medical aid in dying, probably all of those who met the criteria had access to it. And they said that they were surprised by the efforts and resources put in place to make medical aid in dying accessible compared to the resources in place to ensure access to palliative care. So these are presidents of the two biggest organizations in palliative care. And it seems to have ring a bell to the commission because they said that, and that's a good news, because they said that in December 2018 they will release a report as they have started to undertake a collection of data from the institutions in order to document, in particular, the situation prevailing at the time of the authorization application. Well, I mean, all the context evolving around euthanasia. So the person had access to palliative care. So we'll see what the report says, because it could just be great words, but it seems a good step taken to correct at least a little bit that situation. The third major shift was that there has been tragedies that flow directly from the act respecting end-of-life care, which is the Quebec law, and that are not seen as they are. We had deaths of suicidal patients in the emergency department, people that escape or that attempted to their life, that tried to suicide, that they arrived at the emergency and the doctors just let them die. Not one case or two cases. Enough cases that the Collège des Médecins had to send a note to the physicians recalling their duty to save lives. And they said, well, we know that with the law there could have been some confusion. Yeah, why? Because on the one side you tell if the patient wants to die you have to help them, and then people come after trying to suicide. So we thought it was quite a clear request. So it wasn't publicized a lot, just one article. But these are great tragedies. Imagine if it's your son, your nephew, or your cousin, 28 years old, and you learn that the doctor let him die. There's a wave of suicides to put pressure and to extend the law. We had many hunger strikes. And what did the Collège des Médecins did? Whoops, it's not the good one. Back. What the Collège des Médecins did is not to try to prevent or to lower the number. They accompany the physician with a guide to help them suicide by starvation. So you see the social shift that is occurring here in our society. A woman died, committed suicide by putting her car in front of a train because she was refused medical aid in dying. And what did her family said? We respect her decision. That's how people are now starting to think. Just because it was linked to medical aid in dying, the same kind of suicide is now seen as, well, we respect her decision. We, for people here and probably in the rest of Canada too, heard about the compassionate murder of Madame Lizotte, who was suffering from Alzheimer's. Her husband choked her with a pillow. First reaction of the man was, I panicked, I cracked. I mean, I was exhausted. No one ever asked me how I felt. That was the true reality expressing at the beginning. But now he's saying, my wife died with dignity. Because he wants to avoid prison. So he knows that saying that will probably make him. And our first reaction, the first reaction of the politicians should have been, what went wrong with this guy? How could we help him better? But that was not a reaction. The reaction is always the same. How come this poor lady didn't have access to medical aid in dying? A fourth major shift is that people in distress commit suicide with the approval of the state. Before the law, what we were sold is the patient agonizing with 5 days remaining to live and say, if we cannot do anything for him, he's suffering, a couple of days left, why shouldn't we hasten his death? So for people, the common people, it was easy to say, well, I don't know, you're right, we should hasten his death. although the real answer was we should provide him with palliative care. We already had the solution. But so in the Toronto area, there was a study published on the reasons behind the euthanasia in the first year, 4 major hospitals around Toronto. And what came out of that is that people are not asking for euthanasia because of pain. The first reason is existential distress. That's the real reason. What is this? Absence of community, absence of support. The first reason is loss of autonomy. And when you hear that, losing autonomy, hear disability. That's what we have to hear when we hear that. They're talking about, yeah, my autonomy. Okay, so now I see how you look at people living with a disability. The other reasons were fear of becoming a burden, of losing dignity, famous dignity, and of not enjoying life anymore. So the third observation that we can make based on those facts is that there have been a major shift in public discourse, which is grounded in the logic inherent to euthanasia. Before the law, reaction to such cases would have been suicide prevention, support, look for the causes. We don't hear that when we read the articles. We don't see that. We never know what drove that person there. We just know what blocked her from having euthanasia. The criteria that were supposed to protect the vulnerable people are now seen as discrimination, injustice. And that's not surprising, because this is the logic behind euthanasia. Remember that it was sold as a gesture of compassion, a health care. So, if you keep that in mind, the real question is not, why would someone oppose to that? The real question is, why would you say yes to him and no to him? And this has no answer. That's why they're struggling, and that's why we know exactly where it's going. And we'll see a little later how it's where is it now in Belgium and in the Netherlands. There is no answer. Why would you say yes to him and no to him? You say yes for someone who lost 1 arm. I lost 2 arms. Why can I receive that health care? It's not fair. What would you answer? You're right. So, the fourth major shift. What we'll look now at is those very strict criteria, and with the logic that I just explained kept in mind, we will see what happened. It's the logical consequences of that is that the court challenges will multiply, and the extensions are already studied. First criterion, end of life. That was the main argument before the law. They said, it's for people at the end of their life. Well, it's already challenged by 2 people with disabilities claiming their right to have a doctor to suicide them. That's basically what they want. They want to remove the end-of-life criterion in the Quebec law and the reasonably foreseeable natural death criterion in the Canada Act. If we take out this end-of-life criteria or natural, whatever that means, foreseeable death, it opens the door to many more people. Depression, chronic diseases, disability, it's all open to those people now. That's what we have to keep in mind, because sometimes we look at those challenges being made and we focus on those persons, but we have to think, what will it make, what will it have, what consequence will it have on our society, and that's what will happen. Another criteria is the competent and willing. The person had to be competent, able to say yes, and it had to be his decision or her decision, a true, free decision. That's what they said. We saw with the the so-called compassionate murder of Mrs. Issa that I was talking about. We see the shift in the public mind here is that when we talk about competence and willingness, if that falls apart, it means that it will no longer be my choice. It will be my choice for you. And that's a whole different ballgame. And to measure how people's mind have changed on that, if I would have said that 2-3 years ago, I would have been, it wouldn't have passed in the media. But now, look at that. 36 people plan to give up there was 2 surveys conducted for, how do you say, proches aidants? Caregivers, yeah, thank you. Caregivers, one in the area of Quebec City and the other in Sherbrooke. What comes out of this is that most of them, a lot of people want to give up because of the weight of their responsibilities. So that should be a factor of how can we better help them? How can we support them? So that's the kind of population we're talking about. So then knowing that, it's a little frightening to see that 57% already feel a form of pressure to speed up the departure of the person that they care for. 52 are in favor of euthanasia without the prior request. The person never talked about it, and I would be okay to euthanize her. 50% believe that euthanasia could lead to slippery slope. I just see when do I finish? What's my when does my presentation finish?
You've got 10 minutes.
I have 10 minutes
Left.
left.
Yes.
Okay,
And we need
so
questions, so you.
okay, so I'll skip. See, I prepared my presentation as a French speaker, so I managed to say it all, on the other side. But now I'm just speaking a little slower here. So
You had something about children there on the previous slide?
yeah, I have many things important that I would like to talk about. Yeah, there's. We have to know that there are 3. Again, I'm not a lawyer, but I thought a law was this is what is permitted now, and this is what is not, right? I mean, that's to me my view of what a new law is. But for euthanasia, they said this is what's allowed, and these are 3 things that might be allowed later. 3 things that might be allowed in your law. So you're preparing our minds to accept that. So the first one was advanced directives that we talked about with the Alzheimer's, people living with Alzheimer's. Mental diseases as a sole condition to have euthanasia. And the third one is the minor. So the Canadian Pediatric Society conducted a survey to see what are people thinking, what are pediatricians having as an experience. And what came out of that is that parents already raise questions on euthanasia for their children. And evidently, the question comes from the parents more than from the kid. The kid doesn't want to die. 45 pediatricians have already received explicit requests of euthanasia for their child. 45 already explicit requests. So the fourth observation is that the criteria for euthanasia are in the process of collapsing. And as I talked about, the mutation in progress is that we are going from a personal choice to the choice for someone else, or as so-called personal choice. General observation on the law is that after only 2 years of euthanasia, we can say that the Quebec law doesn't work. The statistics explode all forecasts. The safeguards do not work. The law is violated with no consequences. Palliative care is suffering instead of being more accessible. The Commission is overwhelmed and focused on euthanasia. There is constant pressure to extend the criteria. Really quick, I just want to break the myth of the model countries that we talked about, Netherlands and Belgium, because before the law they say, well, we sent people there and everything is going all right, everything is going well, you don't have to worry about that, it's all going to be fine. Well, it's not working in Wonderland. Very quick, what we learned from different studies that were conducted is that 58.8% of euthanasia are not reported in 2007. 1.7% of all deaths, were by hastened death without request in 2013, which means approximately 1,000 deaths a year. There has been a resignation of a member of the Supervisory Commission to protest against the multiple violations of the law. And complaints, because there happen to be complaints from kids who saw their parents got euthanized, they're just dismissed. So what's behind that is that they want to preserve the face of euthanasia. They want to make it as good as it can be sold. Same thing in the Netherlands, 31% of euthanasia are not reported. And that's what's going to happen here. Or that might be what's already happening here. I told you about no consequences in cases of violations. No, if they're not afraid to violate that, will they be afraid not to declare it? I don't think so. 431 deaths without consent in 2015. And between 2005 and 2010, 23% of all provoked deaths not reported. Resignation again of a member of the Supervisory Commission to protest the euthanasia of people living with dementia. I don't know how I'll do all of this, and I don't know where to cut. Just to say quickly that a great step to bring us to a real discussion would be to make the links between, of course, medical aid in dying and euthanasia, and then from euthanasia to suicide. Currently, what's discussed around the world elsewhere, in Belgium and Netherlands, some crazy man constructed a suicide machine with a coffin integrated in that, and he's going to sell them. I mean, 10 years ago, we said, who's that crazy guy? But now it's received. I mean, he's going to sell some of that. In the Netherlands, they're talking about a suicide pill. They say, we don't even need doctors. Just, yeah, fine. Just give us a pill and we'll buy it. If you want to die, you buy it, and that's it. And the reasons behind euthanasia are the same reasons behind, or factors behind suicide. If you just take 1 minute to compare those two charts, you'll see that the other chart is coming from the Belgian Commission report in 2017. These are the reasons evoked and that led to euthanasia. They're the same. Alcoholism. A man was euthanized because he was alcoholic. He said, I tried everything, so it's incurable. Now I want to die because I can't live with that, so it's unbearable. They said, okay, well, that makes sense. Okay. See the logic of euthanasia.
So every drug that comes into my emergency room, we can let die.
Sooner or later, something like that would come here, yeah. Oh, sounds like the end. Quickly, we have to keep in mind that there is a well-known phenomenon of mimetism, suicide mimetism. The more people suicide, the more other people will suicide. When Kurt Cobain committed suicide, we saw many people committing suicide. There's a bridge in San Francisco where people go there to suicide because it's well known. So the way we treat euthanasia now explains the increase of euthanasia a lot. And this studies here shows that it's based on facts, actually. And I have to say that no study demonstrated a decrease in suicide rates. So when we hear that from some other people, that they say, well, this will, no, you just sweep your suicides under the carpet. That's what you do. But nothing can back your claims. So I'll just finish by reading you a couple of thoughts to make you think, and then I'll let you go, and I'll let, I don't know who's talking about after me. These are what I see as dangerous messages that euthanasia endorses and spread in our society. So for euthanasia, death is a solution to suffering. For euthanasia, suicide is an acceptable personal choice that can replace community support. For euthanasia, the fear of the nursing home or the fear of becoming a burden for the family are sufficient reasons to die. With euthanasia, the right to die could soon become a duty to kill. That's what we already see. My doctor refuses. That's what it means. He has the duty to kill me. With euthanasia, death is no longer a mystery, but a medical problem to be solved. Everything else around death doesn't matter. I thought we were human beings. With euthanasia, suffering is an absolute evil from which nothing good can come out. With euthanasia, an old prejudice saying that disability is incompatible with a happy life is gaining strength. And that's horrible. Shame. With euthanasia, suicide is still bad unless it is performed by a doctor. If I do it, I'll go to prison. If a doctor does it, he'll get paid. With euthanasia, suicide is becoming normal because of safeguards that will disappear over time. With euthanasia, patients will soon feel pressure to die faster. With euthanasia, quality of life and autonomy are the supreme principles that define a person's worth in society. With euthanasia, human beings are judged on a scale of quality, like a product on the social market. With euthanasia, dignity is a goal to achieve, not a state of being. It can be bought like a car or lost like a key. With euthanasia, to do is officially better than to be, and it determines if the life deserves to be lived. With euthanasia, old age, illness, and disability are considered indignities. With euthanasia, our social system endorses the medical suicide of thousands of people who simply feel abandoned, misguided, or poorly treated, or just feel bad about themselves. With euthanasia, families celebrate the suicide of their loved one just because they were present when it happened.
Yes.
Other families will be relieved by the death of a loved one who could have lived many more years had he been better diagnosed. Other families will celebrate the apparent deliverance of a loved one who could have lived had he been better relieved by appropriate care. And other families will come out divided and deeply hurt by the medical suicide of their loved one, which will make their mourning almost impossible. We only hear about the people who were happy about that. We don't know the rest of the family. In the end, with euthanasia, precious opportunities to grow in humanity are lost, not because of, but thanks to end of life, illness, and disability. I'll finish by quoting a passage that I read recently, which to my mind summarizes pretty well the principle that we should fight for. Aid in dying should be that the last touch of the doctor to comfort a patient in his last anguish be provided by a hand that heals and not by a hand that kills. That the last look received be a look of love, humanity, and life. Thank you very much.